Now, Cass is not an emergency physician or a cardiologist. She's smarter than the two combined. She's a data scientist, so make sure you ask your complex data science questions for Cass.
Thank you very much for the introduction, and it's my honor to be here. So today I'm going to give you some brief introduction of the results we got from a secondary study for the historic trial, which is implementing risk stratification with the high-sensitivity cardiac troponin I. So the clinical challenge we're dealing with here is that the large number of patients with acute coronary syndrome come into the ED, but most of them actually don't have life-threatening myocardial infarction. And we need solutions that are safe and effective to rule out these myocardial infarctions in the ED to avoid hospital crowding and admission. And our approach here is an early rule-out pathway based on the high-sensitivity cardiac troponin I, which is being implemented in a historic trial to compare with the standard care pathway. So historic stands for high-sensitivity cardiac troponin on presentation to rule out myocardial infarction. It's a step-to-watch cluster randomized controlled trial where we recruited patients from 7 hospitals across Scotland from December 2014 to December 2016. So we had 31,492 patients. On average, they were 59 years old. 45% were women. The trial itself has 3 stages. In the first stage, all of the sites are using standard care pathway, and then we randomized the switch to the early rule-out pathway. In the last phase, which is implementation phase, all the sites will be using an early rule-out pathway, and these patients were followed up for 1 year after discharge. So the inclusion criteria for these patients are that the high-sensitivity cardiac troponin I concentration on presentation would be no greater than the sex-specific 99th centile, which is 16 nanogram per liter in women and 34 nanogram per liter for men, and also no out-of-hospital cardiac arrest or ST segment elevation myocardial infarction. So the 2 arms of the interventions are on the left, the standard care pathway of the patient with a suspected acute coronary syndrome and no diagnostic ECG coming into the ED. And they also have a symptom longer than 6 hours and their troponin concentration less than 99th centile, then they're low risk. And if the, So if the concentration of cardiac troponin is greater than 99th centile, they're high risk, rule in. And the patients who are in the middle, they will be retested at 6 to 12 hours. If the value is still under 99th centile, they're low risk, rule out. And if they go above the 99th centile, then they rule in. And in early rule out pathway, if the patient has a concentration lower than 5 nanogram per liter, then they're low risk. And if they're higher than 99th centile, it's the same as standard pathway, they rule in. And the patients with a concentration between the 5 nanogram per liter and 99th centile will be the intermediate risk group patients, and they will be retested in the ED. And if the change of the concentration is less than 3 nanogram per liter, then they're ruled out. And if the value is greater or equal to, then they will be admitted for further tests. So if we look at the efficacy outcome, we can see that the length of stay in the early rule pathway is about 6.8 hours compared to 10.1 hours in the standard pathway. And the proportion of the patients ruled out in the early rule pathway is about 71%, was higher than 50% in the standard care pathway. And safety-wise, we were looking at the primary safety outcome, which is a combination between a type 1 or type 4 BC, myocardial infarction or cardiac death at 1 year. And as we can see here, that there is no increased incidence for these outcome at either 30 days or 1 year. So the questions we're interested in here is that what are the midterm impacts of this early rule-out pathway if we stratify the patients using their presentation, high-sensitivity cardiac troponin concentration, and if the early rule-out pathway actually outperformed the standard care pathway in both groups, then did we do something differently? Again, the stratification is based on presentation troponin. If you have a lower than 5 nanogram per liter troponin, it's a low risk, otherwise it's intermediate risk. And again, the primary outcomes we're looking at here is the type 1 or 4 BC, myocardial infarction or cardiac death at 1 year. And other outcomes we were looked at include cardiovascular death, non-cardiovascular death, or all-cause death. So if we look at the basic baseline characteristics, these patients in the intermediate risk group, they're older, and a lower proportion of them are actually female. And if we look at the medical history, we can see that a high proportion of these patients already have a previous myocardial infarctions, heart disease, heart failure, and also had revascularization procedures before, like PCI or CABG. And also, not surprisingly, they also already have medication managing these conditions. And if we look at the cumulative incidence of myocardial infarction or cardiac death at 1 year, on the left side, you can see that's the overall population, and you can see there is a reduced incidence in the early role pathway compared to the standard care. And when we actually stratify using the presentation troponin into low and intermediate risk, we can see the similar trend. We also did a survival analysis using the cost proportional high-system model, and we look at all the safety outcomes, including the primary outcome. We can see that both the low risk and intermediate risk, they have a better adjusted hazard ratio well below 1. And I would like to also draw your attention to the non-cardiovascular death here for both groups, right sitting at 1. So that means that our intervention, the impact of intervention is cardiovascular specific. So, come back to the questions we asked at the beginning. Our finding is the early role pathway outperformed the standard care pathway in that reducing the subsequent myocardial infarction or cardiac death after discharge in the midterm follow-up, which is at 1 year. In terms of the second question, did we mention the patients differently? We're still, this is research in progress, we're still figuring it out. In terms of future directions, we'd like to look at even longer term impacts, for example, at 5 years, and to see how the patients are doing after being implemented on the early role pathway. So with this, I would like to thank Demetrius and Ken, which are giving quite a lot of help, and as well as Professor Nick Mills, Dorian here, giving me guidance, and the historic investigators, the whole group. Thank you very much for your attention.
Very good. Thank you, Cass. Panel, audience, questions?
Maybe you can, a quick one. This relates to the future directions. You said that it may impact the long-term outcome.
Yes.
Let's say even if it does impact the long-term outcome, although probably it's difficult because there are many other confounders, how would you interpret the results?
I think we actually did a little bit of investigation in terms of what's the difference between patients actually discharged directly from ED and admitted in the hospital for both groups, so intermediate risk group as well as a lower risk. So preliminary results I had is that so short term, we can see more benefits from the patients that are discharged from ED, whereas long term is more prominent in the group that actually admitted into the hospital in terms of long term. So I think it's probably, we did a better job of stratifying patients, whether to actually release them from ED or actually admit them in the hospital a lot earlier than we did before in the standard care pathway. So I think that's what actually generating the benefits long term.
Are we harming patients in the standard care pathway? Are we harming them?
Then the question is, do we all agree that entering in the hospital is harmful?
I think, of course, I think this is something that I have to say I don't have the domain knowledge for it, but I understand that there are some harm that could be caused during our daily medical practice. But in terms of for the MI specifically, I haven't done any analysis, but maybe after I do some work, I could understand and answer your question better.
Joseph, last question.
Perhaps it's a difficult question, but do you have any explanation why there are less women in the observation group? Is this a standard for other series?
I would say that this is the first time I did this kind of stratification and see that there are actually lower presence of women in the intermediate risk group. In terms of reason why, I don't think I have a clear answer for that yet. But I think if I look for more populations, and then I will be able to figure out why that is, and then maybe women will have a specific treatment. for them, for that group specifically.
Thank you very much.